Good morning, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Pituitary Apoplexy, New Approaches to an Old Problem, is presented by Dr. Adam Mamalek. Please hold as there will be a brief delay while we change presenters.
Yes, so I think you should be able to see my screen. Is that correct?
Yes.
Okay, great. Thank you.
Thank you.
Yes, thank you everyone for attending. I don't see you because of the way it's set up, but I really do appreciate you attending. Briefly, my name is Adam Mamalek. I'm the Director of Pituitary Surgery at Cedars-Sinai Medical Center in Los Angeles. And what I'm going to be talking about today is a somewhat rare problem, but a very well recognized problem for patients with pituitary disorders, something called pituitary apoplexy. And the way I've kind of structured the talk is it's a little bit more on a technical side. There'll be plenty of time to explain, and I will explain what I'm talking about, but what I'm going to do is present a few different clinical cases of patients that showed up with this problem and how they were managed, because it raises issues of what used to be the dogma, you have to treat this disease in this way, and how we're learning over time as both experience and medical care gets better, that treatment options may be much less aggressive than what we used to think of in the past. So just briefly to understand, what is pituitary apoplexy? So pituitary apoplexy is a clinical syndrome, meaning it's a manifestation of a bunch of symptoms. And it's caused by basically some sort of a stroke or a bleeding within the pituitary gland itself. In the overwhelming number of times, there's a pituitary tumor that most of the time people didn't know was even there, and that tumor either dies or bleeds, so it suddenly expands, and that sudden expansion takes up a lot of space, pushes on the normal pituitary gland, on the visual nerves in the area, and causes acute symptoms. And it's usually, as I mentioned, hemorrhage, which is basically bleeding, or ischemia, which is lack of oxygen and dead tissue, both of which cause a swelling. This is something we've known about for well over 100 years. First described, this is a mistake, this is 1889, not 1989. But it was really first described as a clinical entity in an article published in the 1950s. And this group was the first to use this term apoplexy, which means a sudden acute event. Since that time, however, apoplexy has been widely recognized, widely talked about, widely reported in medical literature. I can identify at least 25 clinical papers of large number of patients since 2000 alone. Despite this fact that we know so much about apoplexy, the actual therapy, what's the best way to treat this disease, remains subject to a fair amount of controversy. So what I'm going to do is discuss 3 cases, or 4 cases actually, each handled differently, each with different outcomes, to try to provide an introduction to what the problems are. So the first patient is a 57-year-old African-American female, very good health. She showed up to our emergency department with a several-day history of headache, dizziness, and she had fainted even in the shower and hit her head. When she came in, excuse me, let me go back here, she had a pretty much normal looking blood pressure. This is her oxygen saturation is normal. She had what's called left eye ptosis. That's where she couldn't open her left eye. And the left eye, the eyeball itself couldn't move. It wasn't she couldn't see, the eyeball couldn't move, which causes, of course, double vision. And she had, her actual vision was markedly diminished, 20/200, which means that she sees at 20 feet what a normal person sees at 200 feet. And she was a bit confused. We did some lab tests, and her salt level, her sodium level was low, which is a warning sign for low hormones. Her cortisol level was low. Thyroid function was low. So these are all the signs and symptoms that her pituitary gland is not working correctly. She had this scan, and what you can see is, this is in the area where the pituitary gland is. There's this white material. On an MRI scan, white is blood. So there's blood, there's this growth here, and she actually has a lot of disease in her sinuses. And so this was all felt to be consistent with this thing called pituitary apoplexy, the sudden loss of hormone function, visual changes, confusion. She was started on some steroids, a steroid medicine called dexamethasone, and thyroid supplementation. So we were replacing her critical hormones. And about 18 hours after she came into the hospital, she underwent surgery. At surgery, she had this pituitary adenoma, the pituitary tumor found, with this apoplexy, this basically dead tissue and blood, and everything was taken out. So what happened to her? Well, within a week, her eye went back to normal. Her sodium level came back to normal by 1 day after surgery. Blood pressure normalized. By 3 months after surgery, she came off of her medications. And 9 years later, I just saw her a few years ago. She's on no hormones. Vision is normal. She's on some blood pressure medicine. So she had a full, complete recovery. She had early surgery, and she was treated with medication. That's pretty good. So that seems like that's the best treatment option, right? Operate on someone quickly. And this is her scan 8 years later. You can see the pituitary area looks pretty normal. She happens to have this other benign tumor, which we're not treating at all. So here's another patient. This is a 68-year-old gentleman who had 2-week history of bad headaches, seen by his primary doctor, and an MRI scan was ordered. And this showed a pretty large pituitary mass, 3.3 centimeters. That's pretty large. And it was pressing up on the optic nerves and hypothalamus and the optic chiasm. I'm just going to move this camera for a second. I think it'll be a little bit easier to maybe see me if anyone cares. Came in 3 days later with headache, nausea, double vision, high blood pressure, and had this CT scan. And here you see that this blood again, you see this very large growth pushing up into the brain structures, into what's called the hypothalamus and the third ventricle. So a pretty big growth. So this patient was then transferred over to our medical center in the ICU. I was not the caring physician initially, and the patient was very sleepy. You could wake up, could only tell you his name. The left eye, the pupil was larger than the right eye. Couldn't really check his vision because he was so sleepy. He was given steroids like the other patient, and really a decision was made by the surgeon that was on call to delay surgery. I'm not entirely clear why. So this person did not have surgery initially, had a very high sodium initially, and this is what the MRI showed. You see this dark area, which is basically dead tissue, filling up a lot of space, has a little bit of blood in it. And labs were, generally speaking, consistent with the same problem: low hormone function, low testosterone. This hormone was actually elevated, suggesting he had an underlying acromegaly, a different problem, but that really wasn't his symptom at this time. So this person was watched for about 5 days and was arousable but pretty sleepy. And then I saw him about 5 days after coming in and underwent surgery on day 6. Found a large soft growth. The nerves were intact, but they were thin. I think most of the tumor came out. and it did again show apoplexy. There was some viable living tumor there. Here's the post-op scan. Everything looks great. All right, all the tumors out, all the pressure is off of the brain, so things should be good. Began to improve, but then I'll just kind of, for purposes of discussion, move along, and he kept kind of waxing and waning. He got a little better, got a little worse, got a little better, got a little worse. Ultimately, he actually required a tracheostomy, which is a breathing tube placed through the throat area because he couldn't come off a ventilator. And then he ended up having this mass in his testicle, had surgery, and he had a significant complication from that, not at all related to the pituitary problem, but he ended up developing severe respiratory failure, and then he died. So would he have gotten better? Maybe, but certainly compared to the other person, surgery was delayed, had a significantly worse outcome. Seems to suggest, hey, you know, these patients should be operated on very quickly. But here's a third case. This 53-year-old person had a bad headache, seen in the emergency department. So you're getting a picture of what apoplexy looks like. Typically really bad headache, sudden onset, visual changes, low hormone problems. Had the same workup, head CT done, showed the growth, started on steroids, developed this droopy eye with inability to move the left eye, came in to see neurosurgery 4 days later in clinic, interestingly, wasn't in the hospital, and was actually generally feeling pretty well. So ultimately ended up having surgery, but this is surgery probably done 2 to 3 weeks later. So here's this big growth with the dead tissue in it, some blood pushing up on the optic nerves we can see over here. Very kind of similar situation, not quite as big as the other tumor. So he had surgery 7 days after onset. It was then delayed again because of the concern he was having GI bleeding. Ultimately, 14 days after, surgery came out. Well, what happened? Excuse me. Within a week, his eye got better. He came off his hydrocortisone. He was on the thyroid replacement, but he's otherwise been fine for 10 years. So here is someone who had delayed surgery and did perfectly fine. So early surgery, late surgery with a bad outcome, late surgery with a good outcome. And then finally, this fourth patient, 73-year-old patient, same symptoms, headache, nausea, vomiting, was taking a blood thinner and was on aspirin as well. Came in, had weakness of the movement of the right eyes, vision was okay, sodium was a little bit low. Workup showed his cortisol hormone was low, his thyroid hormone was low. He had this thing called diabetes insipidus, had a pretty sizable growth, almost 2.5 centimeters, showed the signs of infarction and bleeding. Sorry that I don't have imaging here. Severe compression of the gland, etc. And this person was simply observed, did not have any surgery, just given time, kept in the hospital, went home on day 6. He was on steroids, thyroid medication, this medicine called cabergoline, which we often use for other tumor types. And he was seen 2 months later, ultimately completely stopped his cabergoline, but he did stay on steroids and levothyroxine. So he didn't need surgery. His symptoms went away. He did require hormone replacement, but as you'll see, many patients do, and did just fine. So early surgery, late surgery with bad outcome, late surgery with good outcome, no surgery at all with good outcome. So you can see why apoplexy can be a little bit confusing as to what's the best thing. What do you recommend for patients? So now what I'm going to do is I'll review some of the signs and symptoms of apoplexy and what the literature, what medical data tells us about management. So apoplexy is, as I mentioned, headache. Almost more than 80% of people that have apoplexy will complain of headache. Now, this isn't like a low-grade headache. This is typically a sudden onset severe headache. Oftentimes people will say it's the worst headache they've ever felt, and typically comes on, I don't normally get headaches, but oh my gosh, I've had this horrible headache for the last 4 days. A lot of people say they feel it behind the eyes, although that's not really in and by itself diagnostic. It can also be gradual, but by far the most common is this relatively sudden onset. More than half of people will have some kind of deficit with their vision. The most common is that they lose a little bit of peripheral vision. It can be quite severe in some cases. Patients can even present with a blindness in one eye or the other. And then ability to move the eyes. The movement of all the eyes is controlled by nerves that come into your eyeballs from the sides of the pituitary gland. So if pressure is put on the side of the pituitary gland, they often get these nerve palsies with third nerve, which is the one that moves the eye up and down and helps you open your eyelid, is the most common. A lesser, about 17% of people will have an altered level of consciousness, either sleepy or can even be in a coma. Some patients will develop stroke, and then signs of meningeal irritation, which is usually light sensitivity, nausea and vomiting, stiff neck. Let's see if I can. Yeah. So those are the common symptoms. What usually happens? Well, almost all, the majority of patients will have acute loss of hormone function. About 50 to 80% of patients lose steroid or cortisol hormone function. And the signs of that are low salt level, low blood pressure, being sleepy, not being able to eat, nausea, vomiting. And low steroid is a big concern because that can actually be a life-threatening situation. A lot of patients, about 30 to 70%, also lose thyroid function. About 40 to 75% lose gonadal function. In men, that means low testosterone typically. In women, low estrogens and progesterones. And about 10 to 40% will lose prolactin, which for women is important, the combination of prolactin and gonads for maintaining normal menses. Growth hormone is often low, but we rarely test it in the acute setting, so there's not as much data about that. So who's at risk for getting apoplexy? There's a lot of factors that have been evaluated in the medical literature that may increase a person's risk. So this is most typically someone that has a pituitary tumor they don't know about. Sometimes people do know they have a pituitary tumor and it's just being followed medically or just watching it, not doing surgery. So these are some of the risk factors that have been identified over the years. The ones I point out is high blood pressure and people that are on anticoagulant therapy. This means medicines like, could be aspirin, but more commonly things like Plavix, Eliquis, Xarelto, blood thinners that are used for blood clots, heart issues. They're pretty common medications. People that have diabetes, previously risk of having had cardiac surgery, and then there are some less common things that have been related. Interesting, there's a high correlation between having sinusitis, infection in your sphenoid sinus, and apoplexy. Whether it's cause and effect or they just happen to be there at the same time is not entirely clear. How often do people get apoplexy? So what you see here is that apoplexy is a pretty rare disease, actually. You know, pituitary tumors are very, very common. It's estimated that about 10% of population has some pituitary tumor. Most of those are very, very small, don't need anything done about it. But certainly pituitary tumors themselves are not so rare. However, apoplexy realistically only affects about 6 out of every 100,000 people, and there's only about 0.17 episodes for every 100,000 people. It should be 100,000, not a million, sorry about that, per year. Even if someone has a known pituitary adenoma that's not being treated, or residual pituitary tumor, the risk is still extremely low, 0.2 to 0.6 events per 100 person years. So that means either 100 persons in 1 year, or 1 person for 100 years, or any combination like that. So because this risk is very low, even if someone has a pituitary tumor, we typically don't say, oh, you could develop apoplexy. You need to have this tumor taken out. We treat it separately. We treat the tumor as a tumor, and we kind of treat apoplexy separately. About 2 to 12 patients with an adenoma will experience apoplexy, which basically means some degree of bleeding. It doesn't really mean you have that full-blown syndrome like we were talking about. But for about 75% of patients that have apoplexy, that's the first time they even find out they have a tumor. Non-functioning tumors are most common, and then the second most common are prolactin-secreting tumors. Now, if you look at patients that had surgery, so these are people that had an indication for surgery, so different than the general population, even there, apoplexy is higher, but not a super large percentage, anywhere from 0.6 to 10%. For the patients that I've treated here, which is into the thousands, it's about 3.3%, about 45% are, as I mentioned, non-functioning. And the size of the tumor and the apoplexy is the main issue, as you would expect. The bigger tumor, more pressure on things, etc. So this is where we get into the management issues. When I was trained as a neurosurgeon, pituitary apoplexy was considered a neurosurgical emergency. Patient comes in with apoplexy, they need to get to the operating room right away. If they don't, they're going to lose all their vision, they're going to lose their hormone function, they could die. This is a real emergency. And I think that this is still considered the textbook method of teaching for most residents in training for neurosurgery. So the question really is, okay, that's great, but is it really a neurosurgical emergency? And then the second question is, so let's say something is a neurosurgical emergency. It doesn't absolutely mean it requires surgery. It might require something being done, but that something doesn't have to be surgery just because the word is neurosurgery. You're allowed to treat patients without surgery, even if you're a surgeon. And then the third question, do all patients with apoplexy need surgery? Finally, okay, you're going to have surgery. Does the timing of surgery really make a big difference? Does it need to be done as a surgical emergency? And then if these sorts of decisions are made, well, what are the outcome impacts? So if you have surgery, you don't have surgery, early surgery versus late surgery, it can affect the hormones of the pituitary gland, visual symptoms, quality of life, headache, overall survival. How are these impacted? So this has been a pretty debated issue. There have been lots of different studies that have tried to look at this. This is an example of one particular paper that was published in 1999. This was retrospective review. So what that means is people were treated and a group of doctors said, well, let's look back at the medical records of how people were treated and see if we can draw any outcomes. And this is probably the most common way that research is done in medicine, retrospectively, which of course has a lot of problems, bias. Surgeons have a certain attitude toward treatment, the doctors have a certain attitude. There may have been changes in management schema. So you have to take that into account. But there were 35 patients that underwent surgery for apoplexy, and out of 35 patients who had apoplexy, 31 underwent surgery, which means 4 were treated conservatively, right? And what they discovered in their group was that patients with who underwent surgery who had early surgery, which they said was less than 8 days, tended to do a better improvement in their vision than those that had delayed surgery. Same with the visual fields, tended to do better, and same with the eye movement problems. So although here the differences were much more subtle. So basically what they concluded is that if vision improves better if you operate less than 8 days after symptom onset. I'm not sure too many people would say 8 days is early surgery. Most of us consider early surgery 2 days to 3 days after onset. So this conclusion was a relatively old study by our standards, that early surgery does better in improving vision. Here's another study that was more recently published. This looked at 65 patients. So 73% had surgery, 27 were treated conservatively. And again, what you're seeing here is this strong bias towards surgery because neurosurgeons see these problems and we're trained that these are neurosurgical emergencies. So looking at those groups, the surgical patients had more visual problems when in other words, how did they pick who had surgery versus who didn't? Well, surgery patients tended to have more visual problems than non-surgery patients. Surgery patients had more of these eye movement difficulties. But then they looked at the visual and cranial nerve improvement in both groups. So this is typically you're waiting about 3 months or longer. And they concluded that the outcomes were actually similar in both groups. They really didn't see this as a statistical measure. Usually this, what we call a p-value, should be less than 0.05 for the finding to be statistically significant. So these are, in other words, there was no difference in the outcome in how these groups were. And one thing they noted was the patients that had conservative treatment, 76% of them, their tumor shrank anyway, which makes sense. Dead tissue eventually dies and shrinks. So, and then they looked at other studies that were in the literature, and they concluded that really the outcomes were very identical, whether you operated or not, in terms of what people look like at 3 months or so after surgery. Raising the question of, well, how much good does surgery do in the acute setting? So this is the only trial that exists in the medical literature, lets you know how difficult this problem is, with what's called an intent to treat trial. So they set this up in advance, and they admitted all patients with the intention that every patient was going to not have surgery. But then a decision could be made down the line, okay, this person actually needs surgery. And they were only able to do this with 12 patients because in any given hospital, pituitary apoplexy is relatively rare. So they had 12 patients come in with pituitary apoplexy. All the patients did get steroids, which is absolutely considered accepted standard of care. And they only did surgery if they felt a person failed medical therapy. And how they define failure is really was a subjective measure where the surgeons and the other doctors, the endocrinologists, felt that surgery was needed, typically for vision not improving. So 7 out of the 12 were treated without any surgery. 5 had surgery, and the reasons were either vision failed to improve or level of consciousness failed to improve. And when they looked at these two groups, the outcomes were very similar. And what they concluded is giving the steroids did not actually improve visual fields, only surgery did that. And that if there was hypodensity, which means the MRI looks dark, that predicted that the tumor was going to go away. In other words, fresh blood, which looks bright white, suggested there might be more need for surgery. And if not, if mostly dead tissue, then the tumor was likely to go away. But again, you're left with this population of patients like, okay, well, maybe surgery, maybe not surgery, that kind of thing. So now other people have done what's called a meta-analysis. A meta-analysis is where you take all the different papers and research studies that are out there, and you evaluate them for a set of criteria. Did they meet, did they have the number of patients? Did they measure the right things? And you have criteria to say, we accept this paper as part of our analysis. And then you pool all of that data together, sort of to create one big set. And then you see, looking at each study, do they show a particular trend in one way or the other? This means, so for example, favors surgery versus favors not doing surgery. And this is a statistical analysis. So what this study, which again, I admit is not the strongest study, because look how few data sets there really are, and the number of patients, really low number of patients from all these studies over all these years that they could even include in this analysis. And what they concluded was what they call the odds ratio, or the risk of one treatment, or the benefit of one treatment over another, slightly favored doing surgery to improve vision, and what we call ocular motor palsies, those eye movements. But they didn't evaluate endocrine outcomes, and they didn't control for when surgery occurs. Just means surgery at any time point slightly suggested that vision outcomes might be a little better. So it's hard to make too much from that. People have tried to come up with guidelines for how to decide on surgical management versus medical management. This is from the United Kingdom. They put out a guideline for management, which basically says, so you suspect someone has apoplexy, you put them on steroids, you analyze them, you do your scans, you get an MRI, and if the vision is really bad or getting worse, or they are having diminished level of consciousness, then you go to surgery. But all other patients don't necessarily need surgery. Then you can follow them. If they're getting better, no surgery. If they get worse, they go to surgery. Very logical approach. They've developed this tool called a Pituitary Apoplexy score, which basically tries to break out, how severe patients were, who had surgery, who didn't have surgery, etc. But this is retrospective. So what this pretty much tells you is that if people have lower scores, meaning they have less symptoms, they're less likely to have surgery, and there's a certain common sense nature to that. Not sure how useful this tool is, but it's developed. So right now in 2022, we're very comfortable with diagnosing apoplexy. We're very comfortable saying that everybody needs to at least initially be put on steroids. And we know that surgery works quite well, and we know that non-surgery works quite well. So the question still remains, after all these years, what is the best way to treat a patient with apoplexy? And as I mentioned, there's really only one so-called prospective trial, meaning start at time point A and then go forward with only 12 patients to say which is better. And that's the kind of data that we do typically rely on most heavily to make real clinical decision changes. And there's all sorts of problems with most studies, institutional biases. My hospital, we always operate. We don't care. We always operate. My hospital, we never operate. There's a problem of various surgical skills and methods. Some surgeons may be more adept. Some surgeons may shy away from surgery because they're not as adept. These sorts of issues are definitely problematic. There are care biases and who reports the data. Endocrinologists may tend to be less surgery prone, surgeons more surgery proactive. Who manages the patients? And then in the United States in particular, we have medical legal issues. In this country, people sue. This is really not an issue of any big concern outside of the United States. But because there is that concern of lawsuit, there is a bit of a tendency, certainly in the US, to operate. Because, hey, I don't want to take any chances. I can do this surgery. I can do it very safely. I don't want to be accused if there's a bad outcome that it's because I didn't operate. So there is that bias. There are some other issues, like, for example, does one method or the other get people out of the hospital quicker? What about cost? What's cheaper, surgical management or medical management? You might intuitively think that medical management has to be cheaper, but is that really the case if people end up in the hospital, or if they're on chronic medications, if they lose vision? What about getting back to work or other outcome measures? And then unlike tumors, right, apoplexy tissue is, as we mentioned, is this dead tissue, and blood will go away, the tumors will shrink over time. So again, not like most tumors, the goal of surgical decompression is really a little bit less evident than in typical pituitary tumors. So what I'm going to do is just really quickly run through a study that we're just finishing up now that really tried to give the best possible answer to the best way to treat apoplexy. And this is a study that was called the Pituitary Apoplexy Surgical Timing and Outcomes Registry, or PASTER for abbreviation. This is a study that was run through Cedars as the coordinating institution. But as you can see, this was a worldwide study. We had centers from Japan and Korea, France, Canada. Most of the sites were within the US. And we collected data over this 4-year period of time. And the basic idea was we're going to collect data over a narrow window of time where all the sites are both experts in pituitary surgery as well as experts in endocrine management. The techniques are isolated. To get 100 patients pituitary apoplexy in a single institution usually takes 25 to 30 years of data collection. And the attitude is the site will treat however they think is appropriate. Surgery, not surgery, timing of surgery, whatever you want, and we'll just collect the data because each center, particularly outside the US, in the US, may have different biases, different surgical approaches, etc. And then let's see what the outcomes look like. This is easier to do than a prospective trial, which can be very difficult to organize for surgeries. So we started this in November of 2018. We accrued 100 patients, which was the amount statistically we needed. We stopped at that point because we really want to analyze the data. We had, this is actually, some of the data that I'm presenting here is from an older presentation. Actually, we have all the data collected now. As of May of this year, we have fully collected all the data points. What I'm going to be showing to you today is sort of when the data was still incomplete, but nothing has changed that much, I can tell you. So you see that the different sites each enrolled, some patients might have only enrolled one, some sites enrolled a lot of patients. In most sites, there was mix of surgery and non-surgery. In this site, for example, only surgery. At Cedars, we had most patients had surgery. You can see where my bias is. This is at Pittsburgh. So there's a nice mix here at one site. Yeah, Cleveland Clinic also had a lot of non-surgery patients. So we had a nice mix. In the end, out of 100 patients, there was about 2/3 that had undergone surgery and about 1/3 that was treated without surgery. So a nice mix. What you see here is the percentage of this is probably more valuable here, is there was no big difference in terms of gender, male, female, who had surgery versus who didn't. These are slight differences, but these were not statistically significantly different. There were slightly more men that had medical therapy by percentage, slightly more men that had surgery in both groups, etc. So the point is that these ratios are relatively similar statistically, no big difference. So there wasn't a bias by sex. What about age? This distribution, which by percentage is easier to see, is kind of typical for what we see with apoplexy, meaning as people get a little bit older, the overall numbers get a little bit higher. But there was a slight trend toward medical therapy when people were older. See, most of the medical group was over than age 70. So there was a bias, it seems, toward not operating when patients were a little bit older. Whether they came directly to the hospital that ended up treating them or transferred, you can see there was no real difference between the medical groups. So it's not like, all right, if you were directly admitted to the hospital, you definitely had surgery, but if you were transferred, you didn't. There was no obvious differences there. And these are the sites that we analyzed. What about symptoms? So you can see this looks just like a apoplexy, just like we talked about before. Almost all the patients had headache. A decent percentage, close to 40 or more percent, had visual loss, double vision, nausea and vomiting very common, fatigue very common, photosensitivity. So this looks like what you typically see in all the other reported papers for apoplexy. So we're not seeing a different group of patients. Comorbidities, which means other problems. Again, just what we talked about: high blood pressure, on anticoagulant therapy, obesity is a known problem, diabetes. So again, all the things that have been reported in other series. In the surgical series, interestingly, half the patients that underwent surgery had normal full vision, but there was a larger percentage of patients that had bad visual loss or even blindness. Compared to the patients that were treated medically, you see 78% had normal visual fields and less of them had bad visual field deficits. So a slightly different group. The medical group slightly had better vision when they came in. This pituitary apoplexy score, honestly, not particularly useful. We measured it, just suggested that patients in higher score groups tended to have more surgery and patients in lower score groups had less surgery, but this is what you'd expect. I mean, this is the definition of the score. It's not the other way around, that a decision was made not to operate because of their score. Having said this, going forward, you could potentially use that as a guideline. What about hormones? And so red means they have normal hormone function, and gray means it's not working, and purple means we're not sure. So for the cortisol hormone, as suspected, most patients had lost cortisol hormone, a lot had lost thyroid, and then also a gonad function. In the medical group, very, very similar. No real differences in terms of hormone function between the two groups. And what about tumor volume? Maybe the surgery group always had a bigger tumor and that's why they had surgery. Well, as a group, it was slightly bigger, but statistically, this was not a statistically significant difference. So even though patients that had surgery did have bigger tumors, in and by itself, tumor volume does not explain the, it doesn't give a great rationale for surgery. And even looking at tumor diameter rather than just the volume of the tumor, really no big statistical difference. And then looking at the surgical group compared to the medical group, this is really the main difference. In the medical group, there was less optic nerve compression measured as severe on the MRI or moderate optic nerve compression. So everything else looks pretty much very similar, but surgeons tended to operate if they thought there was a lot of optic nerve compression. So that summarizes that. Everything else was the same. This body mass index was not different. Larger visual field deficits in the surgical group. Apoplexy was more common among men, even though adenomas are more common in women. But otherwise, these groups really look very similar to each other. What about time from symptom onset to surgery? So I thought this was very interesting. If you look at most patients had surgery about between 1 week and 2 weeks after symptom onset. A decent number had surgery more than 2 weeks after onset. So this is all outside of what is classically considered emergency surgery timing. Only about 10, 12 patients, I think, out of 100 had surgery within 0 to 2 days, which is interesting. It tells you that despite the fact that we consider surgery for apoplexy an emergency, most places are actually not operating as if it's an emergency. Now, some of that has to do with patients being transferred from outside hospitals. So these are just surgical risk complications. The bottom line is that surgery could be done very safely, but there were readmissions, there were some complications from surgery, spinal fluid leaks, etc. Nobody died, no carotid artery injury groups. The 3 patients had to be readmitted after surgery. In the medical group, nobody was readmitted, and 1 patient had low sodium, and 2 patients had diabetes insipidus. Just different types of tumors, which is not particularly important for a group, just that it's a big mixed group. There was some tumors were viable, there was a lot of blood, and 34 was just dead tissue. Okay. How long did people stay? Well, the surgical group and the medical group, they stayed about the same amount of time. The main difference is that the medical group were more likely to be in the ICU more, and the surgical group stayed slightly longer, but basically, except for the ICU difference, no real difference in how long they stayed. Almost everybody got cortisol. Most patients got thyroid. What you can see is that the medical group tended to get less treatment overall. But overall, reasonably similar, might suggest that the medical group was a little bit less sick. There's some missing data points, which we're dealing with. These have all been collected. Don't want to waste your time with that. And, oh, this is the old, oh, I see, there's that. So what about, so how did people do? There were 43 patients that underwent surgery that had a deficit of cortisol. Only 11.6% of them recovered their cortisol at 3 months. And what about the people that were treated medically? Only 11% of those. So again, identical. And what you can see is that if a person had a hormone deficiency at surgery, whether they had surgery or not seemed to have basically no impact on whether their hormones recovered. So surgery does not appear to improve the chances of making your hormone function better. What about vision? This is that slide, how they looked at presentation. What about at follow-up? So you can see that the overwhelming majority of people in both groups had a return of vision to normal, and they really look quite similar. So this is where it's difficult because the visual group had worse vision at onset. So does that mean that surgery really helped their vision, or had you just sat tight, they would have done generally fine? Or yes, for people with bad vision, you intervene and you improve their vision. So statistically, we don't have any clear proof here that people that had visual deficits at presentation and 3 months later, their vision is still worse. What about work status? Well, before surgery in the surgical group, 75.5% were working. At 3 months, 61% were working. In other words, 81% of those that were working before. And at 6 months, 80% of those were working. What about the medical group? Before surgery, only 37.5% were working. Remember, this was an older group. We said older, over than age 70 was more common. And at 3 months, about 31%, roughly the same percent, 83%, and at 6 months, 83%. In other words, overall return to work status didn't appear to be different between the two groups. We measured things like what are called quality of life indices. They also don't appear to be any different. Headache score, possibly the surgical group had a slightly improved headache, less chance of headache. Again, not statistically significant. But in almost every measure, the surgical group reported higher quality of life scores, meaning their quality of life was better, and less headache symptoms than the medical group. But we don't know what they were like beforehand. Remember, more people in the medical group were not working, significantly more, and older patients may in fact and do tend to report a lower quality of life and more headaches than older patients. So that's probably all that we're seeing here. So what we concluded from this study is that we do have enough patients, the statisticians tell us, to draw statistically rigorous conclusions. So far, as best as we can tell, timing of surgery, not whether you're going to have surgery or not, but the actual timing of when you do it, and even the surgery itself, seems to have a relatively little impact on visual outcomes or hormone outcomes. But it is clear that if someone does have visual symptoms, surgery does a really good job of reversing that. And we also know that from regular pituitary tumors, big tumors that are causing visual problems. Surgery is effective, 85+% of the time in making the vision better. But remember, many of these tumors have been growing for years and years, and there's typically not a rush to take those tumors out. So it doesn't absolutely prove that surgery is better, but it does lean toward a guideline that says if someone has really bad vision, there's probably no good reason in waiting a long period of time to do surgery. You might get away with it, but why take the risk? On the other hand, do you have to operate within a day or two? Probably not. Surgery patients, as you might expect, tend to have bigger tumors, more visual problems, and patients that are treated medically tend to be unemployed and older before the symptoms leading to apoplexy. So that's what we can conclude at this point. We're doing formal statistical analysis right now, and we will be setting this, submitting this for publication soon. And this will probably stand as the most definitive guideline in the literature because of all both the approach, the fact that it's multiple medical centers, it was collected over the same time period. There were no, we tried to eliminate biases from the different medical centers. That's just a group that's involved. What can we conclude from all of this? Basically, pituitary apoplexy is a potentially life-threatening event. I mean, I don't want to minimize pituitary apoplexy. It's a life-threatening problem predominantly because of acute and sudden loss of hormonal function. In a rare occasion, bad apoplexy can cause a coma, loss of consciousness. It's only rarely a true neurosurgical emergency. And I think that this is a big change in the teaching of neurosurgery. Apoplexy is a problem. It needs to be managed. It needs to be managed acutely, very promptly, but it's not very commonly something where a person needs to get into an operating room within a day or they're going to have a bad deterioration. On the other hand, using steroids is an absolutely critical step. All patients, almost unless they're proven that their cortisol function is normal and they have very mild symptoms, almost all patients should be put on steroids right away. And that is pretty much what avoids the emergency nature of the procedure and management in general. I do think there's a bias towards surgery. Most apoplexy patients are seen by neurosurgeons. Neurosurgeons operate because they're surgeons. And so I do think there's a bias. I think in the United States there remains that strong bias, and that's going to take a long time to change. But I do think that the data supports the idea if level of consciousness and visual field deficits are off for very big tumors, that there is a role for surgery, even though it might not have to be done as an emergency. I think that it seems clear there's a bias toward the conservative treatment in older patients or patients that aren't working. And this seems quite justified, by the way. And I do think this is a change in thinking. And certainly the endocrinologists who manage these patients are much more prone toward this. This is one of the reasons why it's extremely important to be managed by both a neurosurgeon, but also an endocrine team. And you really want that team effort in managing to make sure you get sort of the optimal treatment. Outcomes really look quite similar between people that have surgery and don't. And again, early surgery is probably less likely to have an impact, might have a small impact on visual outcomes, but that seems to be about it. So, surgery is effective. It's associated with higher costs, higher rates of complication, and higher rates of readmission than conservative therapy. So again, some of the downsides of surgery. And I think that increased awareness and validity of the conservative management approach is likely going to lead to a shift in overall management over time. It would be ideal to do what's called a prospective randomized trial where patients come into the hospital, they have apoplexy, and they're just randomly put into group A, you're going to have surgery, group B, you're not going to have surgery, and then follow them aggressively to see what happens. Those are extremely hard studies to do, surgical prospective styles. That's the gold standard that would really answer the question. But it might be useful if they have this apoplexy score less than 4, where there's less of a bias towards surgery. So I'm going to stop there and leave time for questions. And I'm just going to, what I'll do is I'll switch back to a regular webcam view. I hope that'll work. And if there's any questions, I'm happy to answer them. Let's see if I can do that. Maybe I'll do it this way. I don't know if anyone can see me. All right. Is there a way to, let's see, are there questions?
Okay, thank you very much, Dr. Mamelek. I'm not seeing any questions from any participants yet.
That's fine.
It was very thorough. It was an awesome presentation. We really appreciate you.
Sure. Yeah, it's a very, to some degree, an esoteric topic, but an important topic to be aware of, particularly if you have a tumor that's being followed. Be aware of apoplexy and signs and symptoms of it.
Awesome. Yep, it looks like we're not going to have any questions today.
Okay.
So we really appreciate you coming out and presenting for us. It was a really great presentation. And this will conclude today's webinar presentation. We appreciate you all taking the time to join us. If you missed any part of today's webinar or you'd like to share it with family members or friends, it will be available on our website at www.pituitary.org. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. And thank you all for joining us. Enjoy the rest of your day.